Greetings. This is Grand Rounds featuring Dr. Pamela Collins. My name is Dr. Gail Wyatt, and I'm thrilled to have the honor of introducing Dr. Collins to our UCLA community. Dr. Collins is a professor of psychiatry and biobehavioral sciences and professor of global health at the University of Washington, where she is executive director of the International Training and Education Center for Health and the UW Global Mental Health Program, an interdisciplinary program dedicated to the prevention and treatment of mental health conditions in low resource settings locally and around the world. Prior to her current role, she was director of the Office of Research on Disparities in Global Mental Health and the Office of Rural Mental Health Research at the National Institute of Mental Health. That's where I met her. Her leadership led to the launch of research initiatives to expand mental health services in Africa, Asia, Latin America, and the Middle East, as well as research to reduce mental health disparities among diverse ethnic groups and indigenous communities in the United States. Dr. Collins completed her undergraduate studies at Purdue University. She obtained her MD from Cornell, her master's in public health at Columbia. She did a residency in psychiatry at Columbia, postdoctoral fellowship at Columbia and Harvard, and she was formerly an associate professor at Columbia at the School of Public Health. Dr. Collins has served in many numerous roles across the world that have been supported by the World Bank, the World Health Organization, and many other organizations. Her own research focuses on the intersections of mental health and HIV care in the United States, Sub-Saharan Africa, and mental health needs of urban adolescents in the global context. She's currently Associate Director of the UW Behavioral Research Center on HIV and Coderex, the center's integrative care core. I met Dr. Collins at NIMH, as I mentioned, and we were very proud at the time that she was filling the role that had been unfilled in this capacity by an African-American woman. She did an outstanding job as a leader and a role model for many of us back in the day. And we hope that she can be a role model to many of you who aspire to do international work and have the concerns that we all share about the quality of life and health, and particularly mental health, because I think Dr. Collins and I share the same feeling that if you don't have good mental health, you don't have health at all. So without reservations, I'd like to warmly welcome Dr. Pamela Collins.
Thank you so much, Dr. Wyatt. What a lovely introduction. And let me share my screen. I think everyone can see my screen, and let me get my presenter view. It's a pleasure to be here. I'm really grateful for the invitation. And I want to talk to you about global mental health and what is global mental health. I'm going to share some of my personal experiences. I'll talk about the field, and I'll end by talking about what we're doing at the University of Washington right now. And would then love to have this a bit of a broader conversation about all of the changes we have experienced in the last year and a half. What does that mean for the way that we think about practicing in our local environments and in our global environments? And so I look forward to discussing some of these issues with you. This is actually an image from the country where I had my very first global mental health experience. This is the south of Argentina. This is Patagonia on a wintry day. And my introduction to community psychiatry really took place here. It took place in a remote city in the Argentine Patagonia, but the story started in New York City in a psychiatric emergency room where I was a third-year resident, and I met Dr. Jose Lumerman, who was an Argentine psychiatrist visiting and observing services in New York City. Little did I know that 3 months later, I would actually be in Neuquén, the city where he lived, with my mentors, Ezra Susser and Sally Conover, learning about community mental health services in this corner of Patagonia. And what an introduction we had. Understanding how to manage serious mental illness meant meetings with provincial Ministry of Health officials, teachers in the local school system, the police and justice officials, insurance providers, primary care doctors who ran the day program and institute that he led, and local artists who created art and did it with people with serious mental illness. It meant walking the half block from the Instituto, which was really an old house refashioned as a clinic with multiple spaces, walking the half block to a cafe on a corner for grilled cheese and coffee, and appreciating how central this clinic was, integrated into the middle of downtown, unlike the placement of many psychiatric facilities or mental health facilities on the outskirts away, replicating the exclusion that people experience in real life. This introductory visit launched a multi-year collaboration that focused on maximizing resources, skills, and capacity to deliver mental health services in integrated, inclusive ways. And I learned a lot from this. Some years later, I worked with the Pan American Health Organization to conduct a qualitative evaluation of mental health services in the neighboring province of Rio Negro. And the story here was one of rights-based reforms emerging after years of dictatorship and a desire to root mental health in the community, to destigmatize mental illnesses, and again, to bring community resources and center community needs while delivering care in the smallest villages and much more challengingly in the larger cities. And what was energizing about these collaborations was the passion, the foundational belief that bringing people marginalized by mental illness into the center of community life was essential, and that we needed to search for tools to address larger social issues from these perspectives as well, of inclusion, of health, of mental health. The next area that I began to work in was this intersection of HIV and mental health, which was really building on the recognition that the social vulnerabilities of people with severe mental disorders, women in particular, whom I worked with, place them at great risk of HIV infection, and as we know, of many other kinds of medical conditions. And addressing this required understanding of intersectional stigma, of contextual risk factors, as well as determining how the health system could support interventions. And I began this work in New York City, worked with colleagues in psychiatric facilities in South Africa, had the opportunity to develop interventions in New York, share those with my colleagues in South Africa, figure out how together we could develop manuals that helped really providers and psychiatric facilities figure out how to do prevention. And in those particular days, this was before there was access to HIV care and treatment, so prevention was really quite the focus. And learning how to collaborate with government so that what we did could potentially have impact beyond our immediate studies and ultimately have policy impact, which is what some of our work did in South Africa. By the time HIV care and treatment arrived, I used these skills to begin to work with people living with HIV in New York, in several sub-Saharan African countries, to better understand and deliver care focused on psychosocial needs and mental health of people living with HIV. And again, the power of learning from colleagues, of sharing our experiences from different contexts, understanding actually the tremendous similarities across settings, particularly in the context of working with families and people living with serious mental illnesses. This was really, to me, this was the heart of global health and global mental health. This kind of exchange, this kind of mutual learning, and the ability to take what you learn and figure out how to apply what's useful in places where you are. I went from a faculty member at Columbia University to the National Institutes of Health, where I was in the National Institute of Mental Health, as Dr. Wyatt mentioned, leading 2 offices. And in that role, I had the opportunity to set priorities, to stimulate funding for mental health and engage a community of global health funders to do the same. And we did that by launching the Grand Challenges in Global Mental Health, which was a priority setting exercise involving people from 60 countries across a number of disciplines, and then determining a list of priorities that the field could begin to address. We went from there to recognizing that a really important piece of what was needed in the context of mental health services was to build the evidence base around how communities can deploy people, their best resources, to meet mental health needs. And we did this with a set of values. First, bring the end users of research, the patients, service users, clinicians, the governments that would sustain interventions, to the table as partners. We were able to directly fund institutions in the countries where the research was happening, allowing them and encouraging them in our first set of major initiatives to create collaborative relationships and hubs with other countries in their region, so that they were actually both conducting the research, building capacity in the regions around them, and then using these consortia for cross-site learning. And we did this over several rounds of funding, eventually creating these collaborative networks of research in Africa, Asia, Latin America, and the Middle East. And also beginning to focus on questions around integration. What is it, how do we fruitfully integrate mental health into the many platforms of care that people seek? Our work led us to think about and define how we thought about mental health research and the research needed to address the treatment gap. And that really can be summarized here to say that there's a two-part goal of global mental health research, and it has to be first to advance science globally while meeting local needs. That equity is critical in all aspects of global mental health research. This means that there must be a diversity of researchers, of study participants, of environmental contexts, and research investments. All of these enrich research into the root causes of mental illnesses, as well as how to prevent and treat them. We found that engaging policymakers and providers early and often could facilitate the uptake of research findings and the sustainability of innovations. None of that is straightforward, but there are some practices that can help facilitate some of these. Fostering research partnerships and regional networks could facilitate multi-directional learning, which was something I felt very strongly about, because that's the value of having a global community. Pilot studies and locally relevant data could pave the way for more sustainable innovations, but moving from the pilot phase to actually scaling things up is a challenge still, and we'll talk about that. The tension between services and research in low resource and particularly conflict-affected settings has to be explicitly addressed. We can study things, but people want services. There's funding for research, and often there's not funding for services. These tensions still exist. And finally, global mental health research must improve local public health research, local public health, period. So these are the things that I began to think about and learn when I was in that role at NIH. We were very interested in figuring out how to encourage skill development, knowledge, and decision-making for multi-directional translation. Meaning, how do we take advantage of the many lessons? And many people at UCLA as well, have been thinking about this. The innovation of a lay health worker delivering mental health services has become a pretty popular area of research in low and middle income countries. But what does that look like in the United States? And how can that be used for specific communities who are experiencing disparities? These are questions that would be a great example of that multi-directional translation. There's been a lot of work around task shifting to deliver interventions for perinatal mental health, for example, in low and middle income countries. Daisy Singla and her colleagues recently began to look at the effectiveness of non-specialist delivered interventions for perinatal mental health in high income countries. Again, building on some of the lessons learned in those experiences in other contexts. Another obvious connection is to understand what can we learn about low resource settings, regardless of where they are, and how interventions can work for rural contexts in the United States or other high income settings, as well as low income countries or middle income countries. So this is that idea of global learning from local knowledge. And all of this, of course, is meant to be able to address the big problem. The scope of the problem is that an estimated 970 million people live with mental disorders globally. That's about 13% of the global population. More than 160 million live with substance use disorders, around 2% of the global population. These are leading causes of disability around the world, and they are a global problem requiring global and local response. And I like the old definition of global health, which says that the global and global health refers to the scope of their problems, not their location. And these are definitely problems that span many locations. And let's look at the trends that have led us to where we are now. So in 1990, non-communicable diseases contributed less than half of overall global health loss, including mental disorders. Even at that time, though, I think most people will remember that the 1990 Global Burden of Disease study, which came out around 1993, I think, first showed us that as a group, mental disorders were leading causes of disability around the world. In the intervening years, we've actually seen a pretty rapid decrease in health burden associated with communicable, maternal, neonatal, and nutritional diseases, and an accelerated increase in the burden of disease associated with non-communicable diseases, pandemics notwithstanding. And what that's resulted in is something like this. You can see this is an image showing us on the top, young people, females from ages 10 to 24 years old. On the bottom, these are males ages 10 to 24. So we're looking at people at that pivotal time of development during which most mental disorders begin. And over the past 30 years, you can see that depressive disorders have risen to the top 3 leading causes of disease burden for girls and young women, with anxiety disorders also rounding that out. And for young males, interpersonal violence and self-harm make the top 3 and have risen to that position over the last 30 years. Importantly, depression remains one of the top 10 most important drivers of disease burden since 1990. Disability in general is the main driver of total disease burden today. HIV is also among the top 10 drivers since 1990. Deaths due to drug use disorders rose sharply over the last decade. In fact, more than half of the global overdose deaths occurred in the United States. And another driver of disease burden is increased deaths from violence in Latin American countries. Again, reminding us that social adversity also drives morbidity and mortality. And this is going to be important for how we think about interventions for mental health conditions as well. So given the scope of the problem, the World Health Organization's Mental Health Atlas reminds us of the limitations we have for the formal workforce. There are about 9 mental health workers per 100,000 people globally. And as you look at this image, you can see that there are incredible differences across countries and across the resource levels of countries, with low income countries having fewer than 2 mental health care providers per 100,000 and high income countries on average with at least 72 providers per 100,000 people. So in addition to the dearth of formal providers, what people actually receive, the care that people actually receive is less than optimal. So these studies using the World Mental Health Surveys showed that a large minority of people around the world, whether you are in a lower income or lower middle income country, or even a high income country, and we'll start with this blue, this light blue represents the minimally effective treatment rates for depression, anxiety, and substance use disorders in low and lower middle income countries, where we can see about 2% of people get what they need for anxiety, 4% get minimally effective treatment for major depression, and only 1% for substance use disorders. And when we look at high income countries, it's an improvement, but it's still far from optimal, with 14% of people receiving minimally effective care for anxiety, up to 22% for major depressive disorder, and about 10% for substance use disorders. So resources, quality of care remain important challenges in global mental health. Now, what's driving some of these challenges? Certainly expenditures on mental health are also less than optimal. And if you compare the years of life lived with a disability, so the disease burden, to the actual percent of total health spending on mental health, you can see that this is nowhere near equitable, whether in low-income countries or high-income countries or countries in between. There is a huge gap in this. There's a huge gap here in levels of expenditure. Similarly, when we look at development assistance for mental health, again, starting with HIV/AIDS, you can see that there are abundant funding, well, and certainly still more needed for HIV/AIDS. But if you look at the millions of dollars per DALYs, there's a disproportionate funding for HIV, some of these other causes of disease, compared to mental and substance use disorders, which we also know are, of course, leading causes of loss of healthy life lived. And yet the amount of funding there doesn't even make the chart. So with these problems in mind, the members of the Lancet Commission on Global Mental Health and Sustainable Development came together to think about the field, where we've been, where we are now, and what might we do for the future to actually improve this state of affairs. And I'm briefly going to remind us of the 4 pillars that this agenda published. And the idea here, as those of us on this commission thought about what's happened in the past, where do we need to go, is to say if we need to focus our activities on foundational ideas, what might they be? And so those 4 foundational ideas start with recognizing that mental health is a global public good and that it's relevant to sustainable development, so that it's relevant beyond the health sector. And in fact, the social determinants of mental health that arise from violence, from fragility and conflict, from disease burden like HIV and now COVID, from extreme urban poverty, all of these, of course, require more than the health sector to address them, and yet they are important determinants of our mental health and well-being. 4 domains of social determinants: economic, neighborhood and community context, environmental events, and social and cultural organization. 4 of these influence mental health as they interact with our demographics, our age, our sex, our gender, what our ethnicity and race means in the place that we inhabit. And another lesson from the commission was that addressing mental health, understanding these determinants, can not only help us improve some of the outcomes for other social determinants, but that there really is a bidirectional relationship for many of these interactions. And this is an area that's ripe for more study and ripe for understanding how we can best intervene and achieve outcomes for both. The second pillar on which the Lancet Commission framed global mental health underscores the convergence of social and environmental experience, genetics, neurodevelopment, and psychology on the brain to produce health or illness. Recognizing that when we are born, we start with brains that are full of plasticity. That plasticity slowly declines over the course of our lives, and our genetics influence a great deal of what that plasticity looks like and how it is manifest in our experience. At critical periods in life, and this blue area is showing us adolescence and young adulthood, there is pruning and differential maturation of neurons. And with that, we also see over the life course, the onset of senescence, beginning at birth, and of course, maximizing later in life. So all of these neurodevelopmental processes are happening throughout life. These critical periods are times at which it's important to intervene, right? These are the times when our interventions for mental health can potentially have wide-ranging effects. Also important to recognize that environmental influences are always present, but understanding this developmental arc helps us understand better, perhaps, where and when we can intervene, and we can prioritize critical periods for prevention and care across the life course. And again, this darker bar is showing us the incidence of mental disorders, again, beginning in youth with this great jump after the age of 10. And of course, again, in older age with dementias and other kinds of neurodevelopmental disorders. The third pillar is around adopting a dimensional approach to mental disorders that conceptualizes mental health as a continuum from wellness to illness, and recognizing that we all fall somewhere along this continuum. And this conceptualization of mental health and mental illness also allows equal emphasis on prevention and treatment of mental disorders alongside the promotion and maintenance of mental health. And I think this last year and a half of the pandemic has helped people to understand, perhaps more than ever, that everyone does fall somewhere along this continuum. And moving from a sense of mental well-being and no distress to non-specific distress, and even to more defined syndromes, is something that we can learn to recognize and figure out how to support people as we move up and down the continuum. The fourth pillar makes human rights a central tenet of global mental health action and emphasizes the critical role that people with lived experience of mental health conditions must play in shaping care, prevention, and research. And you're in LA, I'm here, and this is Bebe Moore Campbell, BIPOC Mental Health Awareness Month. And she herself, who was an LA resident, draws attention to the importance of thinking about human rights from their intersectional perspectives, right? And she says, I'll read her quote here, that while everyone, all colors, everyone is affected by stigma. No one wants to say, I'm not in control of my mind. No one wants to say the person I love is not in control of their mind. But people of color really don't want to say it because we already feel stigmatized by virtue of skin color or eye shape or accent. And we don't want any more reasons for anyone to say you're not good enough. This fourth pillar of human rights says we need to put people at the center who have lived experience because of family members, in the case of Bebe Moore Campbell, who have lived experience because of their own journey with mental illness and rehabilitation, mental illness and recovery. These voices need to be central. So advocacy plays a central role in raising awareness of the need for attention to mental health, and it's an integral part of the dissemination and translation of evidence into actionable policies and plans for communities, for health systems, and policymakers to implement. And this has been an important area of work in global mental health. And as a mental health community, there have been more and more opportunities for us to work locally, while also being connected to a broader community of people committed to moving mental health into health and development agendas. The Global Mental Health Action Network is one such organization that brings together a diverse set of advocates from researchers and policymakers and funders, as is the Global Mental Health Peer Network, which enables this broader reach for people with lived experience of mental health problems. And this aspect of our work is so important that the World Health Organization tracks progress on formal collaborations of mental health systems with service users or family and caregiving advocacy groups, recognizing that this collaboration is integral to one of its objectives, which is to provide comprehensive, integrated, and responsive mental health and social care services in community-based settings. And you can see from these bar charts that globally about 50% of countries are actually doing this kind of collaboration, but this also varies regionally. So these foundational pillars are meant to help us achieve 3 goals, at least. But these are 3 primary goals: to reduce the treatment gap for mental disorders, to reduce the care gap, and to reduce the prevention gap. And by the care gap, I mean the need to not only focus on treatment, but also ensure that the psychosocial interventions and the management of co-occurring medical problems, that all of these are bundled together in order to provide for holistic care for people with mental health problems. And I'll talk a little bit about this. And just to remind us, when it comes to the co-occurring mental and other medical conditions, we know that people with severe mental disorders are at 2 to 3 times higher risk of death due to cardiovascular disease, 2 to 6 times at higher risk of death due to respiratory disease, 2 to 3 times more likely to die from accidental deaths, 2 to 4 times more likely to die from infectious diseases, and 2 to 4 times more likely to die from homicides or violence. So ensuring that we're paying attention to all of this in the context of how we define care and how we define these gaps in care is critical. So let's talk a bit about solutions. To achieve the aims of global mental health, a number of actions are needed for policymakers, for funders, for health system managers, for advocates, and for communities. And I'm going to tell you a bit about how we've been thinking about this at University of Washington from our perspective. So when we think about what are the solutions and where do we need to act, we start with a foundation of international partnerships, of strong and healthy international partnerships on which we can build a platform of implementation science that helps us to take the evidence base and learn how best to apply models of care, how we can implement care, mental health care in different platforms, how we can optimize the use of technology, figure out where and how it's useful, and again, how we can capitalize on resources in any local context by using task sharing as a way of extending those resources. So that's the model that we are using. And the other things that we think about as we implement is, number one, we have to stop dichotomizing mental health and physical health. We know that there is too much intersection. We know that you can't have one without the other. Dr. Wyatt mentioned this at the beginning. It's not useful to dichotomize these. We have to develop and nurture and sustain partnerships. I think importantly, we have the tools. With all of the evidence that's been built over the years, we have tools to build community and workforce awareness of mental health problems and to build community skills through task sharing and technology. They're not perfect, but we have them. And then the next thing we need to do is develop, adapt, and scale appropriate mental health interventions integrated into community platforms. And we think about those primarily in terms of schools, complementary healing or faith-based settings of care, maternal and child health clinics, HIV care or primary care. And then finally, how do we implement what works and learn from that process of implementation? And I'll go into some examples of what this can look like. So integrating mental health into community institutions means meeting and caring for people where they are, where they live, where they study, where they work, and where they pray. And there's some really nice examples of this in the literature. Judy Bass and her colleagues at Hopkins did a lovely trial of cognitive processing therapy for Congolese survivors of sexual violence, showing that training a lay health worker to deliver a cognitive processing therapy was better than a supportive intervention by a service deliverer from a local NGO. And in fact, the people who received the therapy intervention had reduced symptoms of depression as well as reduced PTSD symptoms. And importantly, that reduction in symptoms lasted for 6 months after the study. So this is a great example of a community social service integrating mental health intervention into its care. My colleague Shannon Dorsey, who's here at the University of Washington, has been working with children who've experienced parental deaths, largely due to HIV, and post-traumatic stress in Kenya and Tanzania, and specifically working to intervene in schools. And they've had great success in training both community health volunteers to begin with, and now working with teachers specifically. But in this case, the tools that were critical were the sustained partnerships again, and skills development. They've been working in this, she and her colleagues have been working for the last 8 years or so, working with a team of African therapists who have become expert at delivering trauma-focused CBT in their context and training others in their context to deliver these interventions. Using evidence-based, culturally informed psychological therapies for children and adolescents, using rigorous methodologies for evaluation. And these interventions were effectively delivered in schools, which also not only did they improve mental health, but led to more healthy days in school. And as we know, that more healthy days in school actually has a number of lasting effects on well-being and thriving for young people going forward. We've been able to leverage this experience in Western Kenya, these long-standing relationships that Shannon brings with colleagues in Western Kenya, to long-standing partnerships between Nairobi and the University of Washington, University of Nairobi and University of Washington, with new partnerships with the World Health Organization, with NGOs and county government. And in this case, over the last couple of years, we've been working to help test the World Health Organization's EQUIP platform, ensuring quality in psychological interventions, which is focused on building workforce skills through competency-based training of lay health workers for youth mental health interventions. So this is a consortium with George Washington University and a number of other teams working in both in Latin America, in Africa, in the Middle East, to test out how this competency-based training can work and how this new platform can be effective. And the key here is quality, right? So we've got psychological interventions that can be used, but how do we ensure that people are receiving quality care or quality training that enables them to deliver quality care? Integrating mental health care into faith-based settings. My colleague Dror Benzev has been working with digital tools to figure out how do you support healers working in prayer camps in places where there simply aren't the same number of beds in the health system as there are in these faith-based settings. How then can you optimize and improve the care that these particular providers are delivering? Oye Gareje and his colleagues similarly have tested a collaboration between traditional and faith healers and primary care providers in Ghana and Nigeria, successfully showing that this kind of collaboration can be effective in reducing symptoms and also helping people to find ways of providing care that that are not human rights abusive. I want to talk briefly about integrating mental health into community health services, where the collaborative care model has been one model that we use here at the University of Washington that was developed here. and have been working to figure out how that can be adapted to many other settings. But I'll start with, I think, a study that more people are familiar with, the Friendship Bench, which uses problem-solving therapy adapted for use in Zimbabwe. Problem-solving therapy and through the Friendship Bench has been a really effective way to reduce symptoms of common mental disorders in Zimbabwe, and this is being implemented in many other contexts. Interventions for perinatal mental health care, this Thinking Healthy program, which Atif Rahman first launched in Pakistan, also effective with peers. So not just community health volunteers, but in this study, peers, other moms were trained to deliver this intervention to women with symptoms of perinatal depression. And again, the intervention here was effective. So showing again that a new cadre of providers could effectively deliver the service and also provide an alternative to overburdened lay health workers. My colleague Ian Bennett is building work using the collaborative care model in partnership with colleagues at Can Tha University in Vietnam. Again, focusing on workforce skills development for perinatal depression care and testing the feasibility of collaborative care in the context of community clinics where women go for prenatal and postnatal care. And more recently, Ian and his colleagues are working to figure out how to develop a mobile registry for obstetric behavioral health integration as a part of this work. HIV care is a place where I've been working for many years and excited to see that we are seeing more and more evidence around how best to integrate mental health into HIV care. This is work using the Common Elements treatment approach, which in a real world setting in PEPFAR supported clinics in Mozambique, this pilot work that Health Alliance International, Brad Wagner and other colleagues have been doing in Mozambique was promising this is a non-randomized study, but pilot work, but promising enough that now PEPFAR is investing in scaling this up across Mozambique. So will be a lot to learn from that implementation. So we have some really good examples of research and research investments in this work. The challenge is that the research innovations don't always match country realities, right? In South Africa, for example, a recent study showed that still 86% of mental health care expenditure goes to inpatient care, and nearly half of total mental health spending is at the psychiatric hospital level. So where research is showing us some nice innovations to care, there's still a lack of sustained funding for scaling mental health service reforms in many places. So what works and what's needed? We know that task shifting interventions integrated into community and care settings do show evidence for effectiveness, but there is variability in these outcomes. There's a growing evidence base for dual outcomes. If we manage mental health in the context of HIV, some of the HIV outcomes improve. Similarly, managing mental health in the context of child health or maternal health outcomes, we can see improvement in both areas, but we need more evidence around this. It's important for us to also examine the direct and indirect effects of mental health integration on social determinants, and education is a great start, seeing that taking care of kids in schools leads to outcomes in schools as well as outcomes for their mental health. And finally, we need a better approach to studying implementation strategies, what works best where and when, and a sustained investment in implementation. I'll talk briefly about some of the ways that we are approaching this more specifically and building a network for practice-based learning and implementation of integrated mental health care at UW. And we're approaching these questions with, I'll give you the example of HIV and mental health with the strengths of 3 centers. ITEC, which is a center that I began to direct a year ago, the UW Global Mental Health Program, which I came to UW to lead with colleagues in 2018, and our very new UW Birch, the Behavioral Research Center for HIV, which just was funded this year and we're just launching now. But quickly, just to let you know a bit about these centers. ITEC is the International Training and Education Center for Health. ITEC was founded in 2002. It has led or supported programs in more than 30 countries in sub-Saharan Africa. We currently have a network that involves 10 countries and work in 17 countries right now, but a real focus on health system strengthening, human resources for health, targeted data-driven health interventions. ITEC is very much a PEPFAR implementer, focusing on all three of the 95s, 95% of people getting diagnosed for HIV care, seeing 95% on treatment, and 95% virally suppressed. So this is a lot of the work that we do. The Global Mental Health Program is a multidisciplinary program with three main pillars for objectives, strategic objectives right now. One is to understand mental health intervention gaps and opportunities in diverse community, to build workforce skills to deliver mental health services, and to elevate mental health on the global and local agenda through integrated approaches to prevention, care, and advocacy. And finally, UW-Birch is about bridging research and practice for integrated HIV and mental health care, with a real focus on implementation of evidence-based interventions. And our initial focus will be on learning from communities of HIV care providers as they work to deliver mental health services in settings in the Pacific Northwest, but also in our networks in Africa, the Caribbean, and Asia and Latin America. So with these three centers, Global Mental Health, Birch, and ITEC, we hope to innovate by building the evidence, implement the evidence that we learn, evaluate this evidence as it's implemented in real world settings, learn and disseminate from that. With the mental health group, really helping to focus on situational analyses, optimizing mental health interventions, with our Birch team enabling us to focus down on integrated care and what that means for people who are trying to deliver HIV care and mental health services. And then finally, with ITEC, which enables us to do large-scale implementation, how do we use the research to inform that large-scale implementation? The other piece of what we do is wanting to make sure that the outcome of this work goes beyond us. We do advocacy through publications like everyone in academia does, but also working with multilateral organizations so that what we're doing with mental health integration can be integrated into how UNAIDS is thinking about its work, how WHO is thinking about its work, et cetera. This is an example of UNAIDS' first meeting a couple of years ago on integrating HIV and mental health. And we helped to produce this background document that led this first engagement of UNAIDS. And UNAIDS is now working to develop guidance for countries to integrate HIV and mental health services. And I'm gonna move forward quickly, as I know we're getting short on time. So I wanna bring us to what global mental health is. There is no question that reflecting on 2020, we have to acknowledge the inescapable reality of global interconnectedness. We've experienced trauma related to COVID, trauma related to protests around racism, trauma related to police violence, not just in the United States, but in other parts of the world. And global mental health is also fundamentally about ensuring that we increase equity in mental health outcomes by not neglecting social realities, even as we think about the pandemic, equity by ensuring that we are equipping professionals to know how to think about disparities in the context of this pandemic, which has made them so stark. Remembering people that are at the intersections, recognizing that those disparities that we see by race and by ethnicity are also seen by diagnosis, and the intersection of race and diagnosis has led to worse outcomes in the context of COVID. Finally, global mental health is entertaining these same questions that global health is, calling out traditional power imbalances between providers and service users, between high income and lower income communities, between donors and recipients. We need to ask the questions and struggle with who decides on what we do, who decides how to allocate resources, who has the power to make those decisions, who gives them that power, and what backs up that power. Global mental health is a field with an urgent need to respond. My colleague Deepa Rao and I wrote a call to action for the World Mental Health Federation this year, saying that what we need to do as a community is to recognize and respond to racism in all of its forms across the world as a threat to health and well-being across the lifespan. we really have to support the amazing, ambitious efforts to achieve the Sustainable Development Goals, because this is our key to addressing social determinants in countries around the world. People have targets that they know that they can try to achieve. We need to invest in social and behavioral interventions. We need to ensure access to quality and affordable mental health care and primary care, continue that work, and keep working to reduce disparities in mental health care. And finally, keep talking about power. This is a field that recognizes a vastly interconnected world and values nurturing that interconnectedness for solving difficult problems through a diversity of perspectives. And we have to recognize that power determines how we do that. Mm-hmm. And I'm going to stop there. Thank you so much.
Thank you, Dr. Collins. I'm hoping everyone is giving her applause, even though she may not hear it. She can feel that this was a really outstanding presentation. And now I'd like to invite you again, those of you who have not contributed to questions, to type them into the Q&A at the bottom of your screen. We have a few. We'd love to have more, but as they're coming in, Dr. Collins, I know that you talked about some of the issues being world specific. I mean, stigma is still a huge problem, and we don't seem to be making a lot of inroads to reducing stigma. The same traditional issues that have always been still are. And I wonder, what do you think it's going to need? What do we need to change? Because it seems like what we're doing isn't really making the change fast enough, so that when we do international work, the same problems that we came for are still there when we leave. We're not, the difference is not significant enough for us to feel like we've really accomplished something. How do we get to the next level?
It's a really good question. And I guess part of what I say is, how do we get to the next level here as well? Because we have the same challenges here, right? And so that's where this global thinking comes, is that how do we, and I feel like, there's actually a really robust global activist community in mental health that has taken off in the last, in the last decade, and even more in the last 5 years, I would say. I don't see that same, I think we see that in smaller communities in the United States, but I don't see that on a national level, for example. That same energy that I do see in the global context around advocacy for mental health, and this energy around ensuring that people are centering the voices of people with lived experience. I think that's going to be a contribution to reducing stigma, is once people are accustomed to saying, oh yeah, who are we, whose viewpoints are we ensuring are informing the way that we do our work, right? How do we try and institutionalize some of that? That's happening with funders now. We have a project that's funded by the Wellcome Trust that's about building a global mental health data bank for youth mental health. And that is so centered on ensuring that young people with lived experience are both advisors who are helping the project and understanding and getting input from their colleagues in their countries. At the same time, then of course the study participants will represent the same groups. But I think funders are doing a good job of ensuring that they center the user as voice in what's happening. I think the other question around stigma is maybe a civil rights question, which is that one of the ways in that we have seen civil rights come about is through legislation, right? Not through trying to get people's attitudes to change, but actually through policies that protect people. And I think this is the same. I have a colleague long ago who told me, who has a son who has multiple disabilities, and always said that I don't expect people's attitudes toward him to change, but I want to make sure that he has protections by the law, right? Under the law. And I wonder if we should start thinking about that in the same way when it comes to stigma. Think about the discrimination, right? And how do we actually do away with the discrimination?
And essentially, many of these issues that we're talking about end up in discrimination.
They do.
Person against the other, that deny people the rights. So I like the civil rights attitude, because it's taking too long to really change. And it seems like the world is becoming socially distanced as much as the virus is requiring us to. And people are, really looking at travel. Do they want to travel? Should they take the chance? So we've really got to fight against a lot of reasons that we can continue to think in the same limited ways about people who are different from us, and not see these changes, really realize a more global world, a more welcoming world when it comes to mental health.
Yeah, absolutely. Yeah, I see there are a lot of questions, but I will say this one thing. One of the insights that I think iTech it's personal insights that I've had with working with iTech is that, I can read the newspaper and see what's happening with COVID, but now I actually get updates every week from what's happening in our network with COVID. And it varies, right? The epidemic has been different in so many countries that I think it's easy to be in one place and to forget what's happening in another place. But just underlining your point that we are connected, I think this epidemic is showing that in ways that we haven't been able to express in all of our advocacy, because until everybody is not having a massive surge, none of us are going to be
Exactly
free from that risk. Anyway, I see that.
Yes, do you see some questions that you'd like to take on?
I'm assuming, so let's see. With the non-professional groups used for PSD, like the Ebola crisis work, could those work for Indigenous communities in the United States? I think you have to ask those communities, right? I think part of this is figuring out, I don't see this as much as saying, oh, we have to use this cadre of, oh, we trained lay health workers there, we got to train lay health workers here. I think it's saying, well, what are the resources you have where you are, right? What do they look like? And how can you then equip those people if we don't have enough psychiatrists in the Pacific Northwest. We don't, so that's why collaborative care started, because you needed to use primary care doctors to deliver mental health services, right? Because so it's figuring out who makes sense for the communities where you are, I think. But I think using this knowledge that we're gaining from the global community about how people are experimented with training and deploying different types of people, I think that's the value.
But I also find that people in different countries, and certainly in different parts of the United States, experience different things. You talked about the lived experience. When we have done studies with individuals who are more likely to have PTSD and depression, we found that racial discrimination better predicts the likelihood that people of color will have PTSD and bouts of depression. And our mental health training does not even include questions about how to ask about racial discrimination. And then how do you help the person if they have had experience? What do you do? We've heard about CBT not being effective. Some people think that it is. We don't even have enough guidance to give our training professionals to what, if people have different experiences, then how relevant is your training to address them?
Yeah, you know what that makes me think of is that, user-centered design has become very popular in recent years, right? Ensuring that the end users of work, whatever you're going to do, whether it's a technology, whether it's a psychological intervention, are involved in kind of co-creating and co-designing. And I think you're pointing to ways that we somehow need to systematize that more, so that even when you're in routine clinical training, do you get a chance to actually learn from the diverse groups of people that you're seeing about what would you prefer? How would you like care delivered? What are the issues?
And what helps you?
Yeah, exactly. Right. The cultural formulation helps us with some of that, the cultural formulation interview, but I think we can do more.
I do too. I think that we have so much to do. Well, you and I could talk forever. We have one more minute. I don't know if you'd like to just say something else at your end. We've enjoyed hearing you. This is so stimulating and encouraging, particularly given what we're going through right now. Any parting words?
Yeah, I just want to acknowledge that I feel like I'm seeing from some of the questions, I want to acknowledge the fact that, yes, we have some good research findings, and none of this is complicated, right? Having one great study outcome doesn't mean that you can scale up for everything.
That's
and
right.
We still have to work out what works, how it works, and why, in what places. So thank you, everyone. It's been a pleasure to be with you.
It was a pleasure to have you. Please come again. Thank you, audience, for your warm reception, and we hope that you will give some really serious thought about what we can do to make mental health available to everyone. Thanks again, Dr. Collins.
Okay, bye-bye.
Bye-bye.